All right, welcome to BlackMentalHealthMatters.org. Today's podcast is going to be very interesting. Hello, my name is Elsa. Good morning, good afternoon, good evening, wherever you are. I have two very special guests today, Dr. Brittany Reed and Dr. DeQuavian Cloud. Welcome. Today's topic is going to be on the historical roots of racial disparities in the mental health system, which is going to be a very, very special topic to dive into. But before I get into that, I want to introduce my guests a little bit. I'm going to start with Dr. Cloud. You are a social worker with the BSW from North Carolina Central University. You have acquired your MSW from Howard University in Washington, D.C., and you have also acquired USW from the University of Kentucky. Your areas of interest are African American males, LGBTQ, individuals of color, children and family, and women of color. That sounds like you can write a really huge book about it. So welcome, Dr. Cloud. And Dr. Brittany Reed, you are a recent graduate at the University of Kentucky with a doctorate in social work. You have received your Bachelor of Arts degree in psychology from Tougaloo College and a master's in social work with a specialization in marriage and family therapy from the University of Louisville. Two great minds today. So huge welcome to both of you. And if you can introduce yourselves a little bit. So I'm going to start with Dr. Reed, just because you're first on my screen. If you can tell us a little about who you are, what you do, and why you do what you do, and where you're located.
Okay, hi, my name is Dr. Brittany Reed. I am located in Louisville, Kentucky. I am currently a mental health practitioner with the school system here in Louisville. I have my doctorate and master's degree in social work, also a specialization in marriage and family therapy. As mentioned, I'm also a licensed marriage and family therapy. My specialization is children and their families, so between ages from 5 to 18 and their families. I've did a lot of work working in residential facilities, psychiatric hospitals, and doing a lot of community work and working with community agencies. Also, am an adjunct professor at several colleges and universities. I do a lot of work. My main focus is working with children in their social emotional well-being, as well as providing services for the family. Outside of my 9 to 5 jobs, I do a lot of work within the community of bringing mental health awareness to the Black community. So we're in those marginalized communities, those poor low socioeconomic communities, really on the ground, trying to speak the importance of mental health awareness and providing resources to those communities. So that's me.
That's a lot. I don't even know how you have time to do all that. So that really is an amazing achievement, and you continue to do that for marginalized communities. So welcome. And Dr. Cloud, what about you?
All right, so good morning, afternoon, wherever you are. My name is Dr. DeQuavian Cloud, as mentioned earlier. So as mentioned, I do have my doctorate in social work. Me and Dr. Reed are from the same cohort and same university. I have my master's in social work from Howard University and my bachelor's in social work from the North Carolina Central University. So two historic HBCUs I'm glad to have attended. I'm located here in Charlotte, North Carolina. So my 9 to 5, so y'all gonna have to keep up with me. My 9 to 5, I'm a health educator for Mecklenburg County. So I do HIV and STI outreach and education. So I kind of teach about the importance of getting tested, why we should get tested, especially in marginalized communities. So this year, people of color, predominantly African Americans, and MSM as well. On top of that, I'm also an adjunct professor at several universities as well, teaching in the bachelor's social work program and a master's social work program at 2 different universities. On top of that, I also do a lot of community outreach as well at our local library here. I kind of work with our teenagers, kind of one-on-one and in group, just kind of talking about the futures, their goals, and kind of helping them kind of navigate the college system as they matriculate from high school to college. And then on top of that, I'm also involved with my fraternity, Kappa Alpha Fraternity Incorporated. So I kind of do a lot with that as well, with community outreach. My primary focus, and I know it's kind of a lot, is predominantly African American males, and I'm kind of addressing unaddressed mental health. That's kind of one of my biggest, I think, areas of research for me, only because African American males, we really don't do a lot of mental health counseling. And so I try to get a lot of us pretty much involved to counseling through various conversations, various community connections, and all the time about the community. So that's not only what I do in my day-to-day life. On top of clinical supervision, I'm a supervisor for a few interns, and then yeah, that's pretty much my life, Monday through Thursday.
I think he also forgot to mention that he is an author.
Wow. I was just going to say, wow. I mean, both of you really, it's just, how do you have time to breathe in between all these amazing achievements and still continue? It's so young and such great minds. So it's such an honor to have both of you. And I'm so happy that because you have all these amazing experiences, as well as the fact that, you are firsthand also educating at the same time, also in the counseling side, also in the treatment side. So to be able to see it from the different perspectives, not just from the institutional, but from the educational aspect as well. It's such, I'm just amazed. And to see such Black excellence here with me. So it really is an honor to host both of you on this topic, which is the historical roots of racial disparities in the mental health system, which I'm pretty sure both of you see in your professions and also in your personal experiences as well. So I think this topic itself is very crucial and, one that doesn't get enough discussion, I find, at least from my experience, or it doesn't get enough conversation, not only in the mental health field, but I also believe in the health field as well, all these disparities that exist and what are they? So in general, so what is interesting is that there are tons of statistics that prove that people of color, versus white people are treated differently in the healthcare field. So in today's discussion, aided by your field of expertise and great minds, will hopefully uncover what the historical roots are and how they are affecting Black communities seeking treatment or access to treatment, as well as how they can be, better addressed in the future. And just considering we have a lot more services now that are created, especially within the past 3-4 years, I think we're seeing an increasing trend that mental health is important and mental health should be also of a focus because it is part of the health umbrella. So, let's dive into some of the statistics to say, why do we have these statistics and why are we not doing anything about them? Are we doing enough? So from what I found in the States, for example, people of color are less likely to have access to mental health services than white people. Could this be because of some of these disparities? Who knows? Black men, for example, this one shocked me the most, are diagnosed with schizophrenia 4 times more likely than white men to be diagnosed, which is also a very interesting concept. Is it because it's actually the right diagnosis, or what are some of those factors as well that we will be able to dive into? Black women are less likely to receive better care, especially maternal care, than white women, because we're seeing a lot of maternal deaths among Black women and also people of color, women of color. There's also differences in cultural perceptions around mental health. Could be seeking help or some of the barriers like language or access, or a lot of stigma surrounding cultural differences. It could be due to race or it could be due to ethnicity. So before we get into some of these like disparities and what they exist, we just wanted to be able to define what disparity is. So I guess Dr. Reed, you can go first because you're first on my screen. In your perception or in your definition, what is considered a racial disparity, or what is a racial disparity?
So when I think of racial disparities, I think of it as a situation or a mindset to where services are being offered to everyone, but when it comes to Black and brown people or people of color, it's the rules are different. The perception is different. The way that they health providers perceive our pain or our concerns is seen as different. So therefore the services that is given to everyone is just given a little different. There's an imbalance. There is not consistency across the board for when it comes to people of color. So I think that's where, when I think about racial disparities, it's yes, you're given this opportunity, but it comes at a cost, all because of the color of my skin or my background or the negative stereotypes that you have perceived in your mind about me because of who I am, therefore you treat me differently. But then the behind that is like, well, I gave you this service. I didn't take anything away from you. It was there.
Right.
But how did you give me the service? How was your intentions behind it? And that to me is that level of disparity, when things are unequal or unfair or unbalanced when given to certain populations.
Mm-hmm. Dr. Cloud, do you want to add anything to that?
Dr. Reed pretty much hit on the head, and I think it's also looking at socioeconomic class as well. Mm-hmm. It leads to racial disparity. So I think that when we're looking at it, sometimes we have to look at that. A lot of our families from these low income communities, right? They may not have access to health insurance. They may not even have access to health care in general. And so when they do try to get these treatments, like Dr. Reed said, they're treated as less than. They're treated as, you're really not important right now. We see you, but we don't have to really work with you right now. Mm-hmm. Versus their white counterparts, or, their other counterparts who may have more money, who may come from a better socioeconomic class, all this can kind of lead into that racial disparity, because for some odd reason, when we see Black or when we see brown, we think less than. But when we see white, we think greater than, or we think rich or money. And so, of course, in some offices, depending on who you're working with, you're going to work with the white person before you work with the Black person, because that you'll have less issues and you'll have less, less barriers, because you sometimes feel like that, well, a Black person is going to give me issues, so why do I need to be pretty attentive to their needs and care when they probably just want drugs or something that's some reason they're here. So a lot of this leads to the racial disparities, because it's so many assumptions mixed into services.
Mm-hmm. Yeah, absolutely. I think you both alluded to it, the fact that disparities are essentially assumptions. There are these underlying assumptions that have carried over for God knows how long, especially not just amongst Black people, but I think, or against Black people, but also people of color. The assumption that, because you're Black, you're going to be problematic. Because you're Black, you're going to have, and you alluded, Dr. Cloud, by saying that the socioeconomic status of, that's one disparity. And that's one of the big disparity, not just in America, I think throughout the world, that is, such a false assumption about Black communities, to say that, because you are XYZ, I'm going to treat you differently. And all these XYZs, that Black person may not even be aware of it, which leads to the second question of, because of the disparities, you're treated differently, you're discriminated differently. So how would you differentiate between disparity and discrimination, or how are they complementary as well?
Okay, I'll go.
Go take this. I'm gonna come behind you.
Okay. Thanks. So I think, and it's interesting because I had to really, to be honest, look and do research on my own to try to differentiate the two, because it kind of sounds like, when you look at the definition of both, they kind of sound the same. It seemed like the same experience, especially for a person of color who's experienced these disparities, and just with everything that's going on. It's hard to differentiate between both of those, especially when you're in a situation where it's happening. Mm-hmm. But by definition, I would say discrimination is just, in my opinion, it's just the outright refusal to provide services for a person based on their race and economic status. So I think that's the fine line between the two, because where disparities is like, oh yeah, like I said, I'm gonna give you these services, but there's rules and there's a cost at it, or there's going to be a lack of on one end versus the other for another race. And discrimination is the outright refusal because of the color of my skin or because of my, ethnicity. So I think that's how I differentiate the two meanings. But when in a situation, it can definitely feel like both or the same. So.
Right. Dr. Cloud?
And Dr. Rita is right. She's hit on the nail. So I just kind of come in and follow up behind her with my tidbits. But no, she's right. I think when we're looking at discrimination and disparity, I think disparity is a lack of as in there's a lack of service, a lack of care. There seems to be a big percentage gap between people who are receiving service and those who are not. Discrimination is just straight prejudice. I don't want to work with you because you're a person of color, or I don't want to work with you because you're LGBTQ, or I don't want to be around you because you're a woman of color, and you think you have more power than me. So that could be discrimination. Versus Disparities, I'm just saying, there's just a lack. That's pretty much all there is. And it's just because nobody really wants to work with you, but it's not because of your race or anything. It's because we just don't feel like it's worth the trouble to put in all that work when other people need it more than you do.
Right. I think. Sorry, Dr. Reed, go ahead.
Oh no, I was going to say, like, piggybacking off Dr. Cloud, it's like, we work so hard to finally get a seat at the table, but that disparities is when, we allowed you to have a seat at the table, but we don't want to hear you. We don't want to hear your voice. We don't want your opinion. We don't want any of your knowledge. We allowed you to be here. That doesn't mean we value you or want to hear from you. Just be thankful that we gave you that seat, and we're supposed to be okay with that. So I think that, to me, is the visualization of the two. At one point, you couldn't even sit at this table because of who you are, because how you identify. Now we're giving you this seat, but don't say anything.
Right.
How dare you? Although you're qualified, you have the education level to be here, your voice is important, but we gave you the opportunity. That doesn't mean that you can come in and say anything. And so they stifle your voice, even when you're at that table. I think that's where that racial disparity or disparities come in place in the situation.
Which is discriminatory, right? To say that, you're lucky you have the seat, despite, you debunking all these disparities, right? Because we talked about socioeconomics, which is a huge factor in Black communities, that is seeing as, it can be possible that you dress nice and you speak the white language and you have all these like amazing a code list to kind of back up your work, and you can't be educated. How is that possible? Because you have all these negative attributes. I mean, that's kind of what they are, really. Disparities, at least to me, there's different ways of conceptualizing them, and I think you both did it so brilliantly, because I talked about the actual factors that are seen as, and Black people do know that, and I think they're aware that I'm going to be treated because of this, and I think that's what leads have those mental health effects, is to say, am I going to get this job, for example? Or am I going to have a seat at that table? And am I going to be able to talk even if I get the seat at that table? And, Dr. Reed, like you said, we weren't even allowed to be at that seat like 3 years ago or 4 years ago. And I think a lot has changed, God rest in peace, since George Floyd, but even then, it's still a process. It's still, the disparities like that still exist, like these kind of disparities, right? It's like, now we have a seat at the table. Now we're going to have to let you speak, but are we actually going to take your input into consideration? It's like at the next stage almost, and it's always been decided by that hierarchical structure that we're at the below, or we're not seen as valued. Colored people are not seen as valued members of society. So, which kind of leads to my next question, I think, because we're talking about historical roots, right? Like, where do these come from? Where do these disparities come from? So, how has the mental health system shifted within the discourse of race, I guess, in the past 5 years alone? You can go ahead first, Dr. Reed.
I think that there's been a shift in how we view mental health within the Black community. If I were to take it back a little bit, I think that with the help of social media, even with the help of celebrities is coming out and talking about it, I think that there's been a shift in even acknowledging mental health. And then on top of everything we've gone through with the Breonna Taylor and the George Floyd, it brought into perspective that, we're not okay, but it's just that the world still doesn't love us and accept us, and they treat us a certain way and how they perceive us. And we're tired. So we're tired of having to fight. We're tired of having to continue to use our voices for systems that's not going to change in how they view us and how they treat us. And then on top of that, we still have to be so strong as Black people. You know, the word strength, and I talked about this in my my research in my doctoral program, is the positive and negatives of being strong and resilient. We've had to be that for so long. We had to be strong for our communities. We had to be strong for our children. We have to be strong for the senseless deaths that's going on, and it's taking a toll on us. And I think the idea, and I do want to thank this this generation of kids, this generation that's coming out and bringing awareness to mental health and putting out there, like, these are issues that we're experiencing. See a therapist. It's not stigmatized. You're not seen as being weak. You're not seen as being crazy. You know, get the help. And I think coupled with the fact that although it's still a small number, we're seeing more people of color, Black people coming into the field of social work and doing in therapy or doing therapy, and it's bringing more a better visualization of people even wanting to feel more comfortable in going to therapy because they're seeing people like us that are the therapists and they're sitting across from and talking to, and they feel like this person can relate to their struggles versus how it was years ago. So I think it's a combination of a lot of things, but I think that even the conversation and the acknowledgement of the fact that mental health is a thing and our mental health is not well, and that it's okay to see a therapist, and the conversations around, you can go to church and you can believe in God and see a therapist. It's okay. You know, God made us. God made this profession for a reason. Use the resources. You can't just get well by just having this belief and think it's going to be prayed away. You have licensed people that's on the ground here to help you. So it's okay to have both. So I think it's just a shift in first bringing awareness and even having a conversation of mental health, and then all these other aspects that has been contributed to it to make this the shift in acknowledging and working towards your mental health.
Yeah, I mean, that's an amazing response. Dr. Cloud, anything to add to that?
Yeah, I want me to be following up with my Dr. Reed. It'd be hard, but we're gonna give it a shot. I'm joking. Same thing that she said. Basically, within the last 5 years, like she said, with Black Lives Matter and then we're seeing the gun violence that's going on, there has been a shift, and I think people are starting to kind of see their mortality. Especially African Americans are starting to see their mortality. They're starting to see that, well, heaven is closer than we think, is what I love to say. And I said it to a lot of people, and that, any day could be our last. So we need to take care of ourselves here and now.
Yeah.
And so mental health has shifted. We have started to see a lot of African Americans, get involved in therapy. I'm starting to see a lot of intake of African American males coming in. I've never seen this many males coming to my agency, whether it's for health education, whether it's for mental health counseling. But the increase that I've seen within the last 5 years has been very interesting, because 5 years ago, it was rare for me to get more than 2 males, a month. Now I see about 10 to 15 a month coming in, and I'm like, where y'all come from? Who sent y'all? Because it's all about, I want to get in control of my mental health. I have a lot of stuff going on, and I need somebody to talk to. Like Dr. Reed said, I think it also makes it better when they see me. One of the only male clinicians of color in the agency, especially for my department, I'm the only one. So, there's no other Black African American male who they were used to. It was just me. So it kind of made them feel comfortable that, there's somebody there who I kind of talk to my mental health about, who will kind of understand me and who will judge me. And so this shift is getting better. Like Dr. Reed said, social media, Twitter. If you go on Instagram right now, you'll find like 4 mental health pages, right? Talking about mental health. And I actually like these pages. I like that shift because 5 years ago, we went there to talk about our mental health because we didn't want to feel like a burden. Now, people talk about their mental health, like it's a common conversation. I'm dealing with something today. I'm a little bit depressed, but you know what? I'm here. I'm dealing with it, and I'm here, and I'm present. And to me, that's a major step. And I can't wait to see what happens in the next 5 to 10 years with mental health. And as like Dr. Reed said, this next generation it's really on them, and it's really because of them that we're starting to see this influx of mental health services kind of come into play.
Right.
I do want to add, and I'm sorry, I don't want to interrupt you. I do want to add, on top of all that, I think COVID played a huge role in that as well, and actually forcing people to sit down and be amongst their families, or being at home and just dealing with the world. And for Black people, we had people of color, Black people, we had the higher numbers of deaths and contracting of the virus. So that was a huge shift in the family dynamic. When jobs got shut down and people was working remotely, so being in the home, when kids were taken out of school and doing virtual, I think all those stressors, on top of having to deal with the pandemic, I think that played a role in people acknowledging mental health, and acknowledging that they may be struggling with some things and wanted to reach out in service. And on top of that, then you add on the hyper visualization of the George Floyd and Breonna Taylor. So it was just a combination. We were just hit, especially as a Black community, we were hit really hard for the past couple of years, to where it's like, okay, we're not well, we're struggling, we need help, because it was a lot all over us that we could not deny, we could not hold in. And even for the people, the religious sector, right? If you just, believe in God and you just pray, churches were shut down too. So even that need to go to church to get that healing that you felt was taken away from you. You had to do it online. So I just think it was the world showing us, and everything that was going on kind of opened everyone's eyes to how we're really struggling, and we didn't have those external distractions that we were able to lean into that steered us away from actually acknowledging and working towards our mental health.
Now that's a sermon right there. Because I would agree. I don't got nothing to say after that, but I agree with what you just said.
You and I both. I mean, it is you. Both of you just accurately, depictfully, just shared all the experiences, I think, that all Black communities faced throughout the world, not just COVID, but like the past 5 years alone. And you said so many great points, especially when you talked about it gave us time to reflect. I think it's because there's already some of these disparities that exist that we have to deal with on the daily. On top of that, COVID hit us hard, and lots of Black people died because of health issues. They were affected a lot more because there's a lot more health complications among Black communities, not just in the States, but also in Canada and throughout the world, like I said. But also, I think COVID just highlighted that. It showed, I think, to me, Black people do have struggles, and I think it but we're like, no, we always had struggles. It's just now we're frustrated. We're at a point of like all these services that we use, like church is an institution for mental health therapy to me. Like I think for a lot of Black communities, the majority, because there's no access to, it could be because of like a socioeconomic status, because accessing mental health services is also very expensive, right? So church is it plays a huge part in Black communities, and it's like the therapy you go to. And I think with COVID and I put the past 5 years as a historical point of view than the last 10 or 5, because a lot happened in the last 5 years with the booming of technology and all these mental health apps that Dr. Cloud was talking about. I follow I think 5, I can't even count anymore. And there's also more even, there's one I like about the Black kids and mental health. So now there's a focus on kids as well. And I know Dr. Reed, you're going to talk about it a bit more later because you do work with children. And now it's like at an early age, like start the therapy, start the counseling, because then you're not going to have that traumatic experience in the future. So it really is, in a bittersweet way, a lot of people had to die for people to see that, yes, this does exist among Black communities. They're the most affected out of all people of color. So which leads us to our next question, in both your professional experiences, what is the proportion of representation? So Black doctors versus white doctors. And I know Dr. Cloud, you mentioned it a little bit, how like you being the only male, but people are actually coming to you more. So I see the positives in that. So what is the proportion in the mental health system, and how does that affect or influence those that are seeking treatment?
I kind of start this one. I'm Dr.
Okay.
And I'm gonna tell you why I want to start this, and only because I get to see this daily, I guess. Since I get to work in clinics throughout the week. It's interesting. You don't see a lot of Black doctors. I'm gonna be honest, and you see more predominantly white doctors, white females, white males, or you might see one person of color doctor, but other than that, you see nobody who's really Black. And I didn't realize how bad it was until I actually started having to go to clinics, I actually started working with clients, and a lot of my clients would come in and say, do y'all have a Black doctor? And I look and I say, no, I don't think they do. And I look through the list and I say, no, everybody in here is white. And it's funny how I would say it, but I was saying it in a very serious tone. And they're like, oh, so I always ask for a referral to like a Black, is there a Black doctor? You have a Black pediatrician, somebody's going to actually take care, of me and my needs. And I didn't really understand the importance of it until one day when I worked in DSS, I had a Black kid. And if anybody knows African American skin, we know that you ever heard of Mongolian sunspots or anything adult like that. So Mongolian sunspots are these dark marks that children get, and they can form after birth up to about the age of 4 or 5. And so they look like bruises, but they're not bruises at all. They're just these dark spots until your skin lightens up to your true complexion. So I say all this to say that we had a white doctor who said that the child had been abused, that the parents were beating the child, only because the doctor never seen Mongolian sunspots before on Black skin.
Wow.
We had to get a second opinion from one of our nurses who was a person of color. She said, no, that is Mongolian sunspots. He said it is common in African American children until their skin complexion lights up or the true complexion comes to light. She said, which is normal. She said, those are not marks and bruises. I don't know what you think those were. It was a mess of a case, but it kind of shows the disproportion of why we need more African American doctors, right? Because more and more people want collision color. Like I said earlier, I kind of get to see it. I see it with myself when people come and say, do you have a Black social worker? And they're like, yeah, we do. And they're like, do you have a Black male? Oh, yeah, we have one. We have one. And it's weird. I'm like, my caseload kind of swamped. So let me squeeze you in here somewhere. But even for myself, personally, I have a Black female doctor, and it took me the longest to find her. When I was looking for a primary physician, and I told my mom, I said, I want a Black doctor, preferably male, because it's a little bit less, I would say embarrassing, but it's kind of like uncomfortable, because if it's somebody else talking to a male, I can talk about all these things. I'm the same way with clients. I'm very uncomfortable with female clients because if she comes to me and tells me about female problems, I would tell my female clients, ma'am, I do not know what you're going through. I can only imagine, but I don't understand because I'm not a female. But when I ended up finding my doctor, who's a Black female, she was the only one in the agency. So I still got a Black doctor. She's just female, but she made my experience so comfortable that I never feel like that. I was going to get uncomfortable, and it kind of made a very big impression on me from the professional and the personal side. Because I had somebody who looked like me and who understood exactly what I was going through, and who wouldn't rush me. Most doctors will rush you, talking about, oh well, it's this a fever. We just gonna send you out with some medicine and call it a day. We're gonna run all these tests. We're gonna see exactly what it is and get you treatment for you leave my office. And that to me makes a big impact. Sorry.
No, absolutely. I think what you've experienced as a professional and as a person as well, it's something I can also relate to. And I think when you get a Black doctor that also understands Black health, because we have, some certain genes that are attributed to our African roots that are, like when you talked about it, it's my first time actually hearing about it. And then I said, well, how many children may have been misdiagnosed because of that, right? So even though they have the access to get that treatment, but it's a mistreatment because it's assumed by a white doctor. So I think it really is. I'm the same way with my doctors. I mean, I found one that works. It's hard finding that works with you, that communicates with you the way you want to be communicated. So I'm a vegetarian. Well, I'm predominantly vegan, and I've been that for like the past like 20 years. And it's always been like, oh, you're on the brink of death because you're anemic. And then I found a doctor that was like, anemia is very common amongst women, first of all. And among Black women, it's a lot more common. You're not getting enough vitamin D because you're living in the coldest part of the world. So take your vitamin D, like you're considered low, and but you're not on the brink of death. So I had to find a doctor that understood me. And that was a lot of research. But we're talking about, I mean, the past 5 years earlier, and we're seeing more visibility. But imagine what people had to go through maybe like 10 years ago, 15 years ago, where it's like you're lucky even if you find a woman doctor, like a white woman doctor, especially for females. Like, you know, you feel more comfortable talking about your female body parts to a female doctor as opposed to like a male gynecologist, for example. Because, I mean, to me, it's like, what does he know? Just because he read a book, he doesn't understand like female, but, you know, that's just a perception that is also true. So I think it's incredible that, you know, what you experience as a professional, you can also attribute that and kind of pass that on to your personal and vice versa. So yeah, Dr. Anything to add to that?
Not really, but because he did such a great job. Thank you, Dr. Cloud. But yes, I do think I agree that there is not a lot of, as far as on the doctor side, there's not a lot of Black people that are doctors. I think we are seeing a rise in them, but the numbers are still small. And what I will say, as mentioned, me and Dr. Cloud graduated from the same program in May. But the beauty of our program is that typically with the program that we graduated from, they usually have small numbers, maybe like 20 people that they admitted to the program. But our dean decided to expand that and to bring more. His goal was to bring more students of color into the program. And I'm glad he did, because with our group alone, we graduated what was like 23, 24, 25, just students of color in May. And within our group, it's like of 23 of us, we all produced research that was, just about all of us produced research that was sitting around Black people, Black community, Black children. And that's more research that was out there now than it was before. So if our program didn't have that perspective of widening the numbers and being more focused on bringing in students of colors, then that's less research that will be out there. There's less people that will be presenting on the topics that's talking about the Black community. And so going back to the original question, because we had that lack of representation in these different settings, from social work to OBGYNs to any type of setting where you have people that are in those leadership position or doctor roles, research wasn't out. The communication, the conversations wasn't started. Talking about these Black issues, they might have been there, but now you have a growing number of people that's getting those higher degrees, that's able to provide services to their people, providing education, providing treatments, even more seats at the table. Even if their voices are being stifled at times, they're still there as a representation, and they can do more work to bring awareness to the issue and bring services to combat those issues at a better way now than it was before, even 5 years ago. So.
Yeah, absolutely. I think you highlighted something that's so crucial is research. Research makes a better informed decision, right? When you look at statistics, for example, how are these statistics formed? Even like as simple as, now that when you said that, I thought of like blood work. It's so simple. You're talking about like blood count, right? But where is that compilated list coming from? What are you comparing it to? Is it to predominantly a pool of like white people's blood samples, or is it representative of the environment that you're in? So it's always, and I always question that. I think it's because, like I said, like I have anemia and I have been told, you know, you need breast transfusion so many times by so many people. But then when I found the right doctor, he said, because of where you're from, it's actually normal. Like you're in the normal range based on where you're from. So this is not critical. You're just low. And then he said something to me, and I think you just alluded to that right now, Dr. Reed, is that he's like, because the sample is based on a sample of, it could be predominantly a group of like white people, you're considered low to their standards, but your genetic compositions are different. So from where you're from, it's you're normal, but for here you consider low. So there's not enough research on that. There's not enough research on, African females and their blood samples and why they could differ from like white females or other people of color. So I think research is so crucial because it informs, like I said, better decisions and better outcomes. I think we lost Dr. Reed. Could be internet, so I think we'll just wait for her for a little bit and she can join us. Yeah.
I was like, dang, not really know this hopped off. Technology issues. We gotta love them, y'all.
Yeah, it's the downside of technology issues. It also made me realize, I think, when we lose like power outages or internet, like people can't function without them, I think. And then we're like, I think we're becoming a little too dependent on technology. But I guess we can wait for Dr. Reed, but I can ask the follow-up question, okay. I guess, because
he did text me too. He's trying to get back on now, but he has to follow up.
Yeah, you kind of mentioned it earlier, but it's with regards to provider bias. So the doctor treatment or doctor facilitator, how does that affect the healthcare and the race disparities in the mental health system? So how does the provider? So I guess called provider bias because how does the way a counselor sees or a facilitator or a psychiatrist see how they treat the person being treated? How does it affect, how does it allude to the disparities that we talked about within the mental health system for Black communities?
So I'm gonna answer this first from my personal and my professional side, only because I've seen both again. So personal, one of my doctors, it's a white woman. Love her to death. Actually, when I first started seeing her, I was like, I don't know how this is gonna turn out. End up loving who she was, her personality and everything. And I remember one day when I was going for one of my follow-up visits, he said, if you ever experience any type of neglect, racism, or anything in your healthcare while you're here with me, please let me know. He said, I will not tolerate any type of neglect or any type of racism in my office for any of my clients. She said, regardless of who you are. And it kind of threw me off because it came out the blue. And and her face was very serious when she said it. So I don't know if there was a situation that had arose the day of or something, right. But because I had never experienced it, for her to say that to me out of the blue, it made me feel validated. Like, I have a white person who actually understands that, healthcare, right. Black people kind of don't go hand in hand most of the time. She said, and I remember her telling me that, as long as you're my patient, she said, even if you decide to transfer to my office, you should always receive healthcare as a person, not because of your color, but as a person. And it and that stuck with me. As a professional, I see the same thing kind of. And when I say that a lot of treatment facilities, they're starting to kind of, diversity, equity, inclusion. DEI. I love. This is what I call the Band-Aid effect. It's racism is a very big topic. White people don't know how to deal with it. Let's figure out how to put a Band-Aid over it until we actually figure out how to handle the situation that pops up. And so I call DEI a Band-Aid for racism. I always have. And only because we're starting to see a difference in treatment now. We're starting to see that doctors, those who are not doctors of color, those who are predominantly Caucasian, are starting to actually pay more attention to some of our people of color who come in for treatment, for therapy, and all those sorts. And what's on they're starting to kind of shift, right? They're starting to kind of incorporate more of the Black perspective from their. But here's what goes wrong. They're trying to incorporate from their perspective,
right? It's from their perspective,
not from their client's perspective. And usually, what happens in these situations is we have a doctor. Not color and a person of color, and we got two different perspectives. I'm telling you as a client that what I'm dealing with is genetic, and it comes from my family. Type 1 and type 2 diabetes are prevalent in the Black community. We know this,
right.
What a white doctor gonna tell me or tell us is that okay, you got type 1, type 2 diabetes. Maybe cut this out of your diet. Exercise. We're gonna put you on this medicine. It should regulate, your diabetes. We'll put you on this medicine, to regulate your cholesterol. But I don't think we're looking at it from the perspective of a person of color. Why do you think that we eat these foods? You have to look at the historical factors behind why we eat these foods, and also look at the back in our grandparents' day. And I love to use this analogy. All they had and all they had access to was chicken, pork.
Right.
It's only in the last couple of years that we're starting to see people trying to deviate away from pork. I don't eat pork. For Black men, pork is not healthy, and so I just don't like pork. But I think we have to kind of let people know, especially our providers, there's a reason why we have to eat these foods. It's like, what else can we eat? A lot of us can't do a vegan diet, be pescatarian. A lot of us can't do it's something else, like gluten free or something like that. But there's a reason why. So we're starting to see how treatment is kind of changing now in the office. And then lastly, I think what I'm starting to see as well is that a lot of clients, when they're coming to me, that they always ask me out the gate, and I love it. They say, "What does your treatment look like?"
Yeah.
And I always tell my clients, I said, my treatment is pretty much Afrocentric in nature. And it predominantly uses what we call the Black perspective. It's something I learned at Howard University. And so it kind of allows me to work from an African American point of view. This only works for our clients who are people of color.
Right, of course.
But for our clients who are non-Black or non-Latino, of course, we still work with them, but their treatment plan is different too.
Right.
Because I have to put myself into your shoes the best I can, and try to work from there. It's different when I'm working with somebody who's Latino or somebody who's African American, because I'm in that culture. But it's completely different, when I'm not a white person. So I'm kind of outside looking in.
Yeah. I mean, I love the fact that you said different treatment plan. And I think that's what should have existed a long time ago, is because if, by just looking at someone, for example, when you said like the Latino community, even like language, having someone that speaks the language of that person can make a huge difference in their treatment plans, right? So, and I think it's super, super crucial. Dr. Reed, thank you for joining us back.
Thank you. I apologize. I don't know what happened, but
no problem at all. No, don't worry about it. It happens. We're just talking about a follow-up question on provider bias, and that's what Dr. Cloud is brilliantly answering, which is, doctor treatment facilitator, and how from the treater's perspective, how does that affect the healthcare and the race disparities in the mental health system? So, Dr. Cloud talked about how he provides different treatment plans for different. For Black communities, he has for Black people a different, like an Afrocentric treatment plan, and for Latino communities different, and for other people of color, so the different treatment plans. This is what he provides. And so if there's anything you would like to add to that before we go ahead into the next question.
I mean, that was a great explanation. And only thing I may add, he might have talked about this, just having that dialogue of talking about people, talking to people and getting more insight about their culture, and just using their voices to create those treatment plans, So just asking more of those in-depth questions to get a better understanding of the people that you're working with, to then know how to tailor your treatment for them. So just to piggyback and add on to what he said, he probably said this, and since I was gone, I probably missed it, but that's the only thing I would add, because he gave a great explanation based on what was said or what I heard.
Yeah, I think he talked about. No, you're absolutely right. He alluded to it from a different perspective, in which he's right there. But like I'm saying, I'm just gonna paraphrase. He was saying how white people are learning to listen to people of color more now, especially within the past 3 to 5 years. And I think it's because we talked about diversity and inclusion. How that you're right. It's that Band-Aid. It's that Band-Aid treatment. Where you can't put a Band-Aid on it anymore. You have to discuss it. So it's that they're creating, I think, for me, that uncomfortable conversation within themselves, to say, wow, as a doctor, I should understand this person better. Whereas before it was, Dr. Clay talked about type 1 and type 2 diabetes. It's very common, of course, among Black communities. And, it's, you should, here's the medication for you, here's that, instead of asking, what's your diet plan? What do you eat? Is it different from what we eat? Which it is, right? And food is also so crucial in health because access to the different types of food, because now we have 5 different types of organic foods, and which I can't even, it's just constantly have to catch up with what kind of pesticide it has in it. And I don't think people of color would have time to even look at that, because we talk about the socioeconomic factor, because the more expensive stuff is going to be the high end thing that we're not going to have access to eat, right? So we'll eat whatever is available, and which affects our health in turn, which also affects our. So I guess my follow-up question will be too specific to each of you. So I'm going to start with Dr. Cloud. Now you're first on my screen. So in your counseling experience, is there a lack of representation? You might have explained it a little bit earlier. Is there a lack of representation in the social work community to address some of these disparities discussed above?
There is. I can sit and talk about this all day, but there is a major disparity. I think Dr. Reed said a little bit earlier, there are not a lot of people of color who are in the therapeutic field. There are not, I think, I would say that as a Black male social worker, we are the minority. There are not a lot of us. Just from our doctorate program, 3 of us were Black males who graduated. I graduated from Howard. I think there was only 7 of us who graduated who were Black males. When I graduated from my BSW program, there were about 4 or 5 of us who were Black males who graduated with a social work degree. And as you look at this, broadly, there's not a lot of us. And so this disparity kind of does cause an issue later down the line, especially when our clients want a male of color, right? And the only thing they're able to get is, you have 3 options, sir. We got a Black female, we got a white female, we got a white male. Unfortunately, we have no Black male social workers here on staff, right? And a lot of our clients are like, how's that gonna help? And so there, in my professional view, there is a big disparity there that we're trying to fill in more and more. As more children, I say children, finish school, and especially being the adjunct professor to different universities, it's great when I have African American males in my class. And I can admit I'm a little bit harder on them, only because I know that we need them. The same way my professor told us, he said, you are one of few Black males in this program, and I'm going to be hardest on you because we need you. He said, and if I go too easy, you're going to slip through the cracks, and we're no longer going to have you as a resource. And I've always carried that with me, that when we need it, it's just not a lot of us. We're one of few. And it took me years ago, when I worked in DC, I had a Black male supervisor. And he told me, he said, you are one of few. He said, actually, you're the only one in this agency outside of myself for a Black male clinician of color.
Yeah. I mean, he said that perfectly. I'm gonna just piggyback on that. I think I did, and my numbers could be off, and I think at one point I did look up just what the percentages of Black people in the field of social work, and I think it was like maybe 4%. And just like Dr. Cloud said, representation matters. So with my graduating class having the largest program, having a program with the largest number of people of color ever in any university, that's huge. When we have that picture up on social media, or when we were in the news for that great accomplishment, that's huge. And us being out there and being a representation of this field is huge. We're already at a low number, and what Dr. Cloud said, Black men are even lower than that. There is a rise in Black women getting into the field. So amongst our group, it was 23 or 24 of us. 3 Black males graduated with us, and that's huge. That's huge, but it's also a true representation of how the numbers are still so low. So whereas now there's an uprise in Black people finally getting to the point where they understand the importance of social work want to reach out and get services. On the flip side, you have a small number of Black therapists and Black social workers out there, and we're getting all these referrals. They're like hungry and thirsty for this service, but our caseloads is really high, and we can't see everybody, and we're also human too. So whereas we want to save the world, like we're happy that people are doing it now. Like everything that we've been preaching from the rooftops is finally coming into fruition. But then now we're getting overload. But then on the flip side, it's like we feel bad because we can't see this one person, or maybe we can make room for this person to come in, right? And then even just adding a little historical piece to that is we as Black people are in a field that was originally created to not even serve people like us.
Yeah.
Any medical field, anything, it wasn't meant for us, So now that we're coming in the numbers, we're breaking these barriers, and we're trying, and we're providing services for people that look like us because it wasn't meant for us.
Mm-hmm.
And so it's just so many different perspectives and that goes into this, and it's still not a lot of us. And so we're out here, come be a social worker, be a therapist. We're trying to get everybody we can, people of color, to be a part of this field because they're needed. It was a time I had an intern, and she was struggling. It was a lot to have to work with her. But I told her, I said, we need you out here. We need you. So you can't slack. I need you to be on your P's and Q's. I need you to take this practicum seriously because we need you. We need your representation. We need your voice. We need you. When you graduate, you have to be here for the people. And it sucks because that's a lot on our shoulders, right?
Right.
But it's the reality too. We need more people of color in this field, males especially. Black women are taking over. We coming in by the numbers, but we definitely need more Black males in this field as well, because now we're seeing an increase of Black males wanting to reach out and get mental health services. So they definitely need representation as well.
Yeah, I think that it's absolutely right. Especially like social work is predominantly, was predominantly white women before. And then we started seeing women of color coming in, and then Black women coming in, and then dominating it so brilliantly. So I think we're also normalizing that. Even male nurses, we're seeing a lot more male nurses now because it was considered a feminist field. And I think destigmatizing that was a first step. But I think also fact that there's people, folks like you saying, we need you, so you have to stick to this. And then if I'm a child seeing someone that looks like me doing that kind of work, to say, well, if she's doing it, then I could just break that norm and be that person too. So, and I think that's what Dr. Club is doing, to that he's the only one, but he's not going to be the only one, hopefully, to not carry that burden anymore. And we're starting to see a change. Even in Canada, we're starting to see more and more of that change. Like I have, male nurses in my family, and that's not even like heard of like maybe like 5 years ago, right? So it really is nice to see that it's a slow progress, but one progress is still progress in our minds. It's nice to see from both of you that you're taking the burden of responsibility to want to say that, please, we need this person. So you're educating as you're also carrying on your field of profession. So, and it shows that there's this Black culture, this underlying Black culture to stick together and to really watch out for one another. When I see someone that looks like me, even in the middle of the streets, to say you want to talk to that person, you want to help and reach out to that person. And that is a culture that cannot be explained. You don't need a language, or you don't need different backgrounds. You just need to see because you see yourself when you see that person. So to kind of share that burden, so that they don't, to kind of lift that burden off of that person, so that they don't have to feel the weight that you felt. So, and that's historical in and of itself, because then now our children won't have to face it, or people of this generation will have to face what our parents have faced, or what our grandparents have faced. So it's really is incredible, and thank you for those brilliant responses. The next question, I guess, will be for Dr. Reed, but Dr. Clark can follow. As a licensed therapist, what is the proportion of Black families compared to white or other groups that seek counseling or treatment in your field? This is more to like the marriage and communal and family oriented. So what is that proportion in your experience?
Well, for me and my career path, I've worked in different agencies where my population was already, well, my clientele was already set. So I worked in residential. So these are kids that were removed from their parents' parental care and they're placed there. I've worked or they're they're in the process of going into foster homes and stuff. I've worked at psych hospitals where it was crisis stabilization. So if the family was in crisis, they came to the hospital and then put on my caseload. I work now for the school system. So every kid in that building is basically one of my children. So it's kind of like, I'm not gonna say it's forced, but versus a private practice where people are voluntarily seeking out services. That's different than the agencies I've worked in. So I don't know. I can't really speak from the percentages because of the different settings I've worked in. Have I seen so in the residential, are there numbers of kids, Black children that was removed from the parents? And in residential, yes. But it wasn't as in higher numbers than other races, if that makes sense. So that can speak on, for one thing, it could be that not necessarily that there were kids taken away from their family and in the same situation, but that can also speak from the fact that the African American come from a community-based perspective. So if that child was in the process of being removed, there may have been more family members or people within the community that could take them in and raise them versus them having to go into a residential facility. We can, so even in the psych hospitals, when it's a crisis stabilization, it could be that the same thing. It's the number of Black children and Black families that come in there was low compared to other races. But once again, we can look at it from different perspectives. If it's a kid that's acting up, and the family may say, "Well, I'm gonna pray over, and we're gonna go to church," and even that mindset within the Black community is that with that level of mistrust, that we don't want these people in our business and knowing what's going on, so they may not be accessing the services that maybe other races or other people may want to, that maybe their first resort is to contact the hospitals for crisis stabilization, versus for the Black community there's other things, and going to a hospital or going to the psych hospital may be the last resort, because the reality of the situation is, if your child qualify for in-person, or they would have to stay there overnight. And so the idea of your child not being home with you, it may be the Black families like, we'll rather deal with this on our end versus the possibility of my child having to stay in some strange hospital and I'm not able to see my child. So it could be a lot of factors that go in there. Even working in the school system, depending on where your school is located, that will also determine the population that you serve. If your school is located in a lower socioeconomic community, you may see more Black children there, the higher population of Black children there, versus if you're in another area of town. For me, I have a mixture of both at the schools I work at. So it's kind of hard for me to pinpoint and say that there's a higher number here versus there because of the type of settings that I work in. And then looking at those different factors that contribute to that as well.
Right. I think it's important because you highlighted there's geolocation really is it's a highlighting factor of what perceived experience versus what you see what you get almost based on because social work is dependent on the region that person is in or the location that person is in. So I could see that being variant. Dr. Cloud, anything to add to that?
Actually, no. It's Dr. Reed's specialty more than mine, so I have nothing for this. She was great on that one.
Sounds good. So my follow-up question would be, I think we highlighted a lot of these disparities. And so why do they still exist? Because we talked about in the day and age of social media and with all these mental health services available, to treat mental illnesses, why do these disparities still exist in modern day?
I'm going to say because y'all can tussle with me later because y'all know y'all love to tussle. But we still have our grandparents' generation in these systems. We still have people who believe that Black people are to be really seen or nor heard, but they know that they have to hear us. We still have people who believe that their way is the right way and our way is the wrong way. And we still have people who think, like Dr. Reed said, that right is right. So that is the reason why these disparities and discrimination, if we're going to talk about that as well, still exist in these systems, because that's what we're dealing with. And as we continue to deal with these issues, it's never going to get any better until that generation is out of healthcare, therapy, and other agencies where you have to work with people. And it's going to keep looking like that. We still have people who think that white people should come in through the back. I mean, Black people should come in through the back door. I definitely have been to a establishment like that before, and I surely left that establishment in the same breath that I entered the door in, because I refused to come in through the back door. So I really think that's most of the reason why I still exist.
Mm-hmm. Mm-hmm. I can definitely, I agree. I think there is still a generation that came from a mindset that is still existing, that is causing a lot of these issues to still carry on. Where you have that generation that's still here, and let's be clear, a lot of people within that generation are still in these leaderships and political positions, that are still running, and creating policies and stuff that are hurting and harming the Black community. Those people in that generation are still there and holding office, so they still having this mindset from back in the day. Then that it makes sense, and it attributes to how things are being ran and what's going on today, right? So then you have that generation that still exists, and then you have this younger generation that's coming back and combating that. So I think, to add to his point, it's like, long as we still have those mindsets that's going on, it's still going to, like Dr. Klaus said, that's still going to attribute to these disparities that we have. And like I said, I will always give, I think our generation did a good job too. But the younger generation, with this uprise, change is slowly happening. So if we can have if we have this conversation 5 years from now, I even think 3 years from now, we're going to see a shift. But even 5 years from now, if we continue to be on the track that we are, the world is going to be a totally different. It's going to be totally different in a couple of years. But even we can blame it on that generation, we still have some people that's carrying on that now, not even a part of that generation, because that's what they're taught. We have, the idea of generational trauma and generational traditions is still going on too. As much as you have myself and Dr. Cloud and so many other people that's trying to break those stereotypes or those traumas, you still have a lot of people that's pushing against it, even within our generation, because that's all they know. And it's not necessarily a bad thing. It's more so of perceptions of what you were being taught and the values that you were taught and how you perceive things, and carrying on that idea. Even if we look at the word strength, right? And we have to be strong. And we, especially as women, we have to be strong Black women and be there for our family, be there for, our community and our children. You have to ask the question, then when do I have time to stop and work on my mental health? I got to be strong, So that can be attributed to the years and generational teachings that we've learned over the years. But then also in the reality of today, if we don't take care of our children, who's going to, we have to protect them. We're also living out in a world where, yes, we're aspiring to get all these degrees and we're successful, but we still need to make change. Change does not happen. We're still making change, and we have to fight. And we're dealing with the pressures of the world and the stress of, even from the job, from the community, from our families. When do we have time to stop and work on our mental health? When do we have time we might need to go to that psychiatric hospital to get on medication, but who's going to take care of our kids? I got to make money. So it's, all, like I keep talking about, these different factors come in, from the past and now, that contributes to these things that's happening. So when we do get help, we still have to deal with all these barriers, these disparities that happen towards us. So then why should we have to even go out and deal with that knowing that it's going to happen? But I still also have responsibilities. But then I also don't want to deal with the foolishness that's going to happen when I walk into this doctor's office, you know, and even my life is on the line when I come in here. So why deal with that? I would rather just deal with it on my own, even though it's not the best way, than deal with all these other factors that's going to come with it.
Right. I mean, yeah, that is, you're saying everything that I think we're all feeling. I think you're your own therapist. You have to become your own therapist, because you're telling yourself, I'm going to be fine. I don't have time to deal with this, because you're thinking of all these other XYZ burden of responsibilities that could also be carried on, generationally. And it's a lot, even being a woman of color, just being Black woman. I feel like we're always at the bottom of the pole of that that structural set where it's all the burden of responsibility starts the day that we come into the world, especially as Black women. And I think especially now I see that what we talked about, I think you both said it, it's the generational gap. I think there's like a tug of war between the archaic mindset of what the world should be and should remain the same, and then there's the world right now. And I feel like our generation is more the experimental generation, where we're like, we know that archaic mindset, but we also know what's happening, so we're adaptive. I think we're the most adaptive out of current generation. Is more, they don't know what happened, so they kind of locked out, because it's been cleared out through like our generation for them, which is good, because we're paving the way so that they don't have to feel the pain, they don't have to feel the pressure, they don't have to be they don't have to walk through the path of feeling racial discrimination or microaggression, those XYZ factors that we've all faced throughout our time. So it is a generational thing, and I really hope to see that incremental change, like you both alluded to, Dr. Cloud and Dr. Reed, that we're already seeing positive change. It's happening at a very slow pace, but it's still happening, because I look at it as, and that's why it's important to say historical, because we're saying, well, none of this existed 5 years ago for Black people. We never had a seat. We were never given that. Now, even though our voice can be silenced, we still have a seat, and we're going to say, you know what, we're going to speak up regardless of your opinions, because we belong here just as much as you do. I think that's so, so, so important. And thank you for answering that so brilliantly. And I know we follow up to this question, and I know we've talked about it a little bit, but in your professional experiences, has there been interventions? And I say intervention, I think it's because the last 3 years, the world intervened and said, what happened to Taylor, what happened to George Floyd is not right. And that's a huge intervention to say, you know what, these people are exhausted. They are actually feeling it. And, you see that, and that's why I'm framing it from that context, like it's an intervention. So has there been interventions to combat some of these historical disparities on race within the context of mental health system?
I'm going to let Dr. Cloud go.
I had to think on that one. Hold on.
You too.
Yeah, because I want to say yes so badly, but I also want to say no so badly. So I want to say yes and no here. And only because we see some solutions depending on the agency. You might have solutions. Depending on the agency, you may not have some solutions or some strategies in place. Like we talked about earlier, DEI is to me is recent, because in the last 5 years we've heard about diversity, equity, and equality and exclusion. I keep saying equity, equality and exclusion, but it's only been within the last couple of years that you really be hearing about other DEI. DEI is we have DEI, the DEI initiative, and I'm like, where did this Band-Aid come from? Right? Yeah. Like, that's why I keep calling it a Band-Aid, because it's like it came out of the woodworks. It's been here, but it wasn't this spoke about. Then all of a sudden we got all these conversations on race, racial disparities, and then all of a sudden everybody and mama is a DEI expert, DEI training. I have a DEI certificate. I think Dr. Reed has one too. Probably.
We went to the same training.
we went to the same training, right? And so it's kind of like, okay, we have this DEI certificate. What are we doing with it? Because everybody and their mom is DEI, and so that's going to be the overall strategy is diversity, equality, exclusion, send it to the diversity team. We can look into it. That's going to be our solution for this, and hopefully nobody will look too closely. So yeah, yes and no. that's really how I see it. It's really not that many. Yes, that we are yes, that we are getting more African American people to participate in counseling and therapy. Yes, that we are starting to kind of listen more to African American women about their bodies, especially in the health here, because African American women have the highest rate of fatality, especially during childbirth. That's why I applaud women who decide to have children. Um, you know, I'm a man. I have nothing to say on this subject. Any woman who decides to bring a child into this world, I applaud you because of the risk that's associated with it, and knowing that in the healthcare system, unless you have a team of physicians who are just like you might go overlooked, and that's scary. Especially coming from a family of all females, it's always scary. That's just my opinion on that.
Yeah.
For me, I think just like Dr. Cloud said, yes and no. For me, I think that right now the world is in the awareness phase, to where we are aware that these issues are going on. So then we can attribute to the people that's using their voice to speak out, like Black people are suffering. You're killing Black people. Police, you're killing Black people at alarming rates when as compared to a white person that's getting arrested. So I just think we're in the awareness phase, but I don't know if there's actual interventions that's being put in place. I was actually, when thinking about that question, I actually looked to see. I think that with this awareness phase, I think that birthed the DEI that Dr. Cloud was talking about. So now it's like, okay, now we know this issue is going on. We need to bring more people of color in leadership to show that we're more culturally competent and inclusive. I think that's a start. And I also think with now that the numbers is coming out that Black women are dying at higher rates during childbirth, it's more so like now these healthcare systems and these agencies are like, okay, now we are aware of this issue. What can we do as a hospital to try to combat this issue? So then it's like, let's incorporate cultural competency trainings and having more dialogue around race and cultural issues. But I don't know if any interventions are being put in place, but the conversations are being had. We're aware of it, and so we're trying to be more competent, right? That's great too. You can be competent about every culture and every race, but think about when you're in that situation and how you treat that person. I've talked about strength. If I'm a Black woman coming in, and I'm pregnant, I'm telling you I'm hurting. Yeah, you went through all the competency trainings and modules, but if I'm telling you I'm in pain, are you going to listen to me? Black strength is associated with the Black community. Strength is associated with Black women. If I tell you that I'm in pain and then you dismiss my pain as being, oh, it's not that serious, or you misdiagnose me, it doesn't matter how many modules you went through for cultural competency, you didn't listen to me. And if you know that strength is associated with us, why are you diminishing or dismissing my pain as if, oh, you're strong, she can deal with this, or she's med seeking, or she's this? So, like I said, we're going through awareness phase, but the numbers are still not decreasing. So is there interventions really in place? We can talk about from a social work perspective. You have critical race theory. We have a lot of theories that we learn, anti-racism theories that we've learned in our program. But even when you bring up critical race theory in the school system, they're shutting it down. So even when things are trying to be introduced to try to acknowledge these issues, these systems are shutting those down. So therefore, in my opinion, interventions are not incorporated because nothing is changing. Conversations are being had, but nothing is really being put in place to actually bring change to this issue, in my opinion.
No, I completely agree with both of you. It's in that awareness phase. I think that hit me because it's a phase, right? What's going to be the next phase? What has happened for that intervention to occur? Because right now and I hate those DNIs, it's just, what's up with trainings? Whenever a crisis happens, they're like, oh no, we have to train this person so that he could be he cannot be racist, or he cannot be. But then, like you said, are you going to listen to me? I think that's what it is we're not being listened to enough. And if I'm telling you my problem, if you were to treat me just like another person the same way, and I think that's what disparities are, right? You're looking at me differently, then you're going to treat me differently or mistreat me differently. Therefore, you're going to misdiagnose me. So it's a simple conversation. It really is conversation. If you really think about it, sitting down and listening to, you want a doctor that listens to you. And Dr. Clyde was talking earlier how, he wanted to find the right fit for him to be a patient for. And I'm the same way. It's all about who listens to me. So, I chose a doctor that was a vegetarian because he knows my diet just as much as I do, because he's also on the same diet. So we talk about the different, nutrition options and things like that. Just a conversation as opposed to one that rushes you. And then you're telling him, as a resilient Black woman, to say, if I'm telling you I'm in pain, that means I must really be in pain because I can tolerate it usually. But if you're dismissing me, then why do I go back to you? So and that's why I coined it intervention as opposed to addressing, because that would be, yes, it's being addressed, but is it really being intervened? And it's a tough one to answer, and I think you both answered it really well. For the sake of time, I'll just have two more questions. So how can these disparities be better addressed in the current dogma of mental health system? So what can one do as an individual or a person of color or a practitioner or as an ally even? Because that allyship is really important. And that's something that we don't often discuss when we talk about race or mental health services, because we say this versus that. And it's like, well, the allyship is important. That sharing that space is important. So what can be done in order to combat some of these disparities that exist today?
I would say that having those conversations and really listening to the person that you're working with and providing and catering service for that. No one's the same, right? So you can't give a cookie cutter type of treatment for every person. Even me as a Black woman, I have different hats and different titles that I carry, right? So I'm Black, I'm a woman, I'm a therapist. But even though I am a part of this community, right, my experiences are different even within that community. And it was when we were in our program, we learned about these different theories, and one that stood out to me is called standpoint theory, where you can have a person who is a part of this culture and can experience everything throughout that culture and have those same and share those same issues and those same experiences, but that person is still an individual. So they have their own individual experiences, even with all of that, right? So I am a woman, I'm Black, right? So I can hold space with that with Black women and say, yes, I've experienced discrimination, sexism, gender bias, but then I'm also a woman who, I don't have kids. I'm in a different field. I'm in social work. I've been in different settings. I've experienced my own different biases and microaggressions and stuff. And yes, it's all Black people has experienced that, but what was my personal experience? So then when I am going to find a therapist or I'm working with someone, I need you to understand that I can be a part of this larger system, but then I'm also an individual, and treat me and my experiences as an individual, then therefore cater treatment and services around me, around my individuality as a person that stands within this broad system, if that makes sense. So I think not only listening, but then taking that extra step to look at this person as an individual that had their own issues and tailored treatment around them. And keeping in mind all the other issues that she's experienced or that person experienced as a Black person living in this world and dealing with the issues within society.
Right. All the titles you have and all the titles you're given by society, at the end of the day, you're also a person, you're also an individual. I think it's a really, really beautiful response. Dr. Cloud?
Ooh. Dr. Reed, yes. Because this is something I was talking about earlier when I was like, there are different treatment styles for everything. And she's right, there are. I think I always tell people, and it may sometimes come off as a little, I'm going to say rude, I also people, if you're not Black, don't offer Black solutions. And I know people kind of don't understand what that means. And so kind of let me explain. If you're not a person of color, how can you offer us a solution from the Black perspective? You don't understand exactly what you're speaking of. You can't tell me, well, reduce your pork intake. What if that's all I got access to? You don't understand where I'm coming from. You're not in the same socioeconomic class as me, sir. You don't know that, I got 3 kids and food stamps is all I get right now to provide for us. You don't gotta use food stamps. You don't gotta use WIC to make sure that your baby has milk, right? Mm-hmm. So don't give me advice that's Black in nature when you as a black person don't understand the prevalence behind that advice, right? And that's what I meant earlier. Say different treatment for everybody. Everything is different. If I have a client come into me, like Dr. Reed said, I occupy multiple spaces. I'm Black. I'm a male. I'm a social worker. So I'm occupying these spaces, but each of my experiences will not be the same, regardless of those titles that I'm holding. So I may offer you advice. I may say, man to man, you need to cry. You need to just go ahead and just cry and let that all out. But as a social worker, I might tell you something completely different. Please don't kill yourself. I'm gonna have to have you IBC, and I'm trying to avoid that. Let's talk about it, right? It's all different because I have to look at it from a different perspective each time. It's not always going to be, client is presenting with suicidal ideations. No, my client is depressed, so I need to kind of come out of social work mode and go into brother mode, father mode, the big cousin that you really look up to, who actually can kind of talk some sense to your head. I have to meet you where you connected, and sometimes that means I have to step out of my shoes as a social worker. And when I worked in a juvenile detention center, I was never a social worker cloud. I was never Dr. Cloud. I was just Mr. Cloud. I was a doc. I was Quay to some of my kids because I was that big brother that they didn't have inside the facility. I was that father figure, that uncle. I was the one that would tell you, listen, what you doing ain't gonna work for me. And what you doing is why you here. Please don't make me knock you aside your head while you still here. If I need to knock some sense into you. But I came from a place of concern and love, and my juveniles, especially my males, they understood exactly where I was coming from. So they respected me more because I wasn't talking to them like they were children. I treated them exactly how their age was. I'm going to talk to you like you were a teenager, and I'm going to talk to you how I got talked to sometimes. What you doing ain't working. So what do we need to change? And when they got released, I used to always tell my juveniles, if you come back here, it's going to be me, you in the streets, and I'm going to win. So let that be a reason to not get reincarcerated. And I laugh because one of my boys, and he used to work in counseling, one of my boys came back and he seen me. I looked at him. He said, hold up. He said, now before you beat me up, I said, I'm listening. He said, it wasn't my fault. I said, all right. I said, I get off at 4:30. I'm going to be down there at 3. Have your shoes on. But he knew I was joking. But the guards knew I was joking because that was just how I connected with him. He always used to call me like, his big brother. So I had to come at him like a brother would, like, what you doing is stupid. So I need to tell you what you're doing is stupid. What are we going to do? Because if I see you here for the 3rd time, it really is going to be me. And he never came back after that.
Yeah.
Never. And that's the difference. And that's what it means when you work with people in different treatment manners. It ain't gonna always be that. Well, I understand where you're coming from, or my favorite line that I never use. So what I'm hearing you say is, or what your feeling is, or so the rap is all back around to the beginning question. I don't do that type of therapy. It's more that real base treatment, right? That all right. So what you're going through is this. Now, how we want to handle this is the question. We can do this 2 different ways, and I'm gonna do it your way. We can get ghetto with it, or we can keep it upscale. You choose. But I'm gonna support you in whichever action. Now, if it results in you going to jail, I do not testify, and I was never your therapist. It depends on how we feeling that day. But you gotta have that. I have that. You gotta have it. because that's you meet your clients on where they kind of where they're at. And I do have them clients. They be like, I want to bust his windows out. Well, girl, I'm with you. Flatten all 3 tires while you at it, because you do all 4. Insurance gonna cover it. And, the other clients be like, I just can't get over him. Girl, let me tell you what my grandma say. Well, one man won't do, another will. Get you another one. He'll take as much time as you need. Get you another one, and let me meet him so I can vet him for you. Y'all come to therapy together. We're gonna work together, but it works. It works.
Having those conversations,
yes, it's those real conversations. And I think that's what it means when I say that's how we bridge these disparities and these gaps, because we meeting you where you at. I'm not trying to meet you where I'm at, because I got 3 degrees. You may not have it. So I may have to change my sentences, change my words around to what you understand. That goes to that health of literacy, right? That goes into that financial literacy. I got to change stuff around. If the only thing you know how to do is sell drugs, and that's how you learn how to do math, guess what? In therapy, I'm going to sell drugs with you. We're going to talk. We're going to use drug terminology, because that's the best one I'm going to get to you. It's how you meet your clients. I can't sit there and say, well, So what it sounds like is you making some bad decisions. No, sir, you out here slinging coke. So exactly what is it going to get you in 5 years? Or how much profit can you put away if you don't get arrested? And my clients love that realism, because it's kind of like, okay, he kind of understands where I'm coming from, so I can be more comfortable. So, and anybody who's watching this, if you do sell drugs, don't actually tell your therapist that. Please don't. But sometimes if you feel like it, it's something about to write it down. But I'm just saying, I have clients who tell me the honest truth, and some things I'm like, I'm not to be subpoenaed. So just be careful what you kind of telling me later in these conversations. But I rock with you on it. I got you.
Yeah, that's so brilliant. I mean, you're talking to them like a person, and that's what Dr. Reed is alluding to, is I'm all these things, but I'm also a person. So treat me like a person. And that treatment plan you talked about, Dr. I mean, just both like, wow, just brilliant responses. It really is listen to me. Understand my level, understand where I come from, understand who I am, just understand me simply by listening to me. And I think that's the takeaway message really is, like you're saying, you're really talking to them, you're talking to 3 different individuals, Dr. Cloud, in 3 different ways, 3 different approaches. You're listening to them and you're creating a treatment plan, naturally even, not as Dr. Cloud, but as Mr. Cloud, to say, this is how I'm going to teach you. This is language you speak, I'm going to speak your language, like I don't know it, but I'll try to understand it by understanding you. Therefore, I'll create that plan for you. And that creates not just a space, but comfortableness, to say, oh, I can talk to this person. Oh, I didn't know I'm capable of being treated. I'm capable of being helped. And it's a 2-way conversation, right? Because then they're less likely to come back to you, because 1, they don't want to get beat up, but 2, but they also actively listen. And it really is so, so brilliant. And thank you for those incredible takeaway responses. I guess my last question would be, where can people find you, you 2 brilliant minds, and where can they come to you if you have social media pages or any other place where you would want people to reach out to you for? Dr. Cloud, you can go ahead.
So for me, you can find me on Instagram at drcloud_southernbow. I know it's a lot, but I do not have a Twitter right now, so that's kind of in the works. Instagram is kind of when you see more of my professional side. I ain't gonna tell you my Facebook, because if you see Dr. Cloud outside of the profession. So if you want to see me on professional side, you want my Instagram. I always tell people that. But no, you can actually follow me, Dr. Cloud. Southern Bow. If you do want to follow me on social media, it's Dior St. Cloud, so st.cloud, and you can easily find me on there as well. I kind of post a lot of mental health stuff, realism, and kind of meet my clients there. A lot of my Facebook posts, you'll kind of see that I am kind of connecting with people, especially African American males, about mental health. So a lot of my posts is about mental health, love, and pretty much how do we take care of ourselves as Black men.
I am behind on the social media game. I'm still, as the young kids would say, I'm still the old lady on Facebook, strictly. But I do have an Instagram. I had to actually look it up. It's my personal one, but I am going to create a professional one and a Twitter. I was taught to create a Twitter. So my Instagram is bsreed03. You can follow me there, and until I get my professional. I have an email if you need help or want resources. My email is my first and last name, Brittany Reed, lmft@gmail.com. So Brittany Reed, no spaces, Brittany Reed, lmft@gmail.com. But I promise I'm gonna get more social and get make some more social media professional pages and get that out there. So once I do it, I can reach back out to you and send it to you. And if you want to put it on your platform, that'll be greatly appreciated.
Oh, we would love to have that. That's exactly what we need, is to keep these conversations going, to have brilliant minds such as both of you to kind of keep the conversation going, but to also know that there are these amazing resources out there that exist. Even for me, such a learning experience today from both your perspectives. It's been such a pleasure and an honor to have. My mind's still going crazy around with all your degrees and your PhDs, and it's just amazing to see and so refreshing. So we're very grateful to have you, and thank you so much for joining us, and hopefully you have a very wonderful day and an even more wonderful week, and thank you for having us.
Thank you for allowing me to be a part of your platform. I really do appreciate you allowing me to have a seat and listen to me and have my voice be heard. So thank you for the opportunity.
It's a pleasure. Thank you. Bye.
Thank you.